multiple sclerosis, this is a really interesting example because multiple sclerosis is a devastating condition, but a very varying condition. And there's certain types of multiple sclerosis called remitting, relapsing, so it can be quite bad for a while, then it can get better, then it can get bad. So it can follow this sort of this sort of up and down path where it can be bad for a while, it can be good for a while, and then in between. And so there was a physician that developed a procedure for multiple sclerosis, and felt that this was effective, the surgical procedure, and it was a procedure to tie off the veins in the neck because to open up the veins in the neck because he felt that venous congestion in the brain was actually causing the procedure, and that was later shown to be wrong. And I'm going to show you exactly what happened to that in greater detail later, because that was quite a famous example, and the surgeon that did that in the end did the right thing. So I'll cover it now. So this was his first publication. The guy called Paolo Samboni. He's from Italy, and he had this procedure. Now, people with multiple sclerosis were flying from all over the world to have this procedure done, this procedure to open up the veins coming from the brain. And he probably earned a fair bit of money doing this procedure. But to his credit, he actually did a randomized controlled trial where he looked at doing this procedure compared to not doing this procedure. And he conceded that his own therapy, once a source of hope, was largely ineffective. And to his credit, at the time of the initial study, even though he was doing the procedure, he said the results of this pilot study warrant a subsequent randomized controlled trial. So this is the way it's supposed to happen. Sure, have some crazy idea that might work, and that's fantastic. That's how we discover things. I have no problem with this at all, as long as you then test it in a scientific manner. And if it doesn't work, then you give up. This is the way it should happen. Unfortunately, what happens is we come up with an idea and then we stop there and we just do it. And we operate on everybody and we never actually test it properly. And unfortunately, that's the history of surgery. So what surgery historically relies on is these three things. A plausible mechanism, but you can find a plausible mechanism for just about anything. So I really don't think a biological plausible mechanism is necessary, but it is not sufficient, because I can make up a biological plausible mechanism for just about any crackpot operation. There's always some laboratory evidence, but as I've said, laboratory evidence does not always translate into the real world. And observational studies. So these are seeing people get better. So these are not controlled trials, not randomized controlled trials. And what should be used to determine the effectiveness of anything is the method with the least error. And the method with the least error is basically science. Science is a tool of error reduction. That's all it is. People say, oh, science, tells you the truth. It doesn't tell you the truth. It tells you the least wrong estimate of the truth. And you can reduce random error, you can reduce systematic error. So these are just the principles of science. But the randomized trials with low risk of bias are the best way of doing it. Now, unfortunately, randomized trials, they're raised as the gold standard, and they probably are the gold standard, but they're not always done well. So people think whenever they see a randomized controlled trial, well, that's the answer. And often nothing could be further from the truth, because they're often done very badly. I give this example here of two knee arthroscopy trials. And one of these trials, published in 1995, is the worst randomized controlled trial ever published in the field of knee arthroscopy. It is a terrible randomized controlled trial. I don't think the patients were blinded. I'm not sure that it was truly randomized. It was done very poorly. And this one, published in 2013, was another study showing looking at placebo surgery. And this was perhaps the highest quality surgical trial I've ever seen. Not only were the patients blinded, but the people who saw the patients afterwards and measured their outcomes were blinded. The statisticians who did the analysis were not told which group was which. They were just given sort of an A and a B. They weren't told which one was real and which one was placebo. And even the doctors who did the study wrote the article without knowing which group was which. They had to write two versions of the article, depending on whether A was placebo or B was placebo. And then they signed a contract saying that they would stick to that version of the article after they were unblinded. So this is about the lowest quality study you can get. It's a very famous study for being one of the best studies in surgery. So this study, of course, showed no difference between the two groups at all. And this study, which was a terrible study, showed that surgery did fantastically. And if you didn't have surgery, you were worse off. So how much randomized trial support is there out there for orthopedic surgical procedures? We published this study a few years back in PLOS One. You can look it up. And we looked at 3 hospitals in Sydney, Australia, 3 different hospitals, one very large trauma referral hospital, one very large elective hospital, and one kind of mixed hospital that did a bit of everything. And we looked at over 9,000 orthopedic procedures, everything that was done. And we looked at the evidence for it, and we said, how many of these procedures have been subjected to a randomized trial comparing them to not doing the procedure? And we found that it was roughly around about 50% had been subjected to a randomized trial. And that's actually not unusual. So in a lot of medicine, you'll find that only 50% of what we do has been subjected to a randomized trial, comparing it to not doing it. However, what we found was that of that 50%, around half, there was at least one trial that showed that it was not effective. So we were doing a lot of procedures. So this is, for example, knee arthroscopy was one of the procedures, shoulder arthroscopy. There was good evidence that it was not effective, and yet we were still doing it. So we have 2 problems here. We have an evidence gap where half the things we do have not been tested, and we have an evidence practice gap where half the things we do that have been tested don't work, but we're still doing them. Also published more recently, this was just published in the last 12 months in the journal Pain, where we did a study, a similar kind of study, looking at the evidence for surgery for chronic musculoskeletal pain. So we looked at the most common surgical procedures done for pain. So we took out things we didn't look at surgery for fractures, for broken bones, because that's not really done for pain, that's done to restore function. And the pain of a broken bone would get better anyway. We looked at people who were operated on specifically for pain. So this is conditions like arthritis, carpal tunnel, back surgery, a whole lot of things. And we looked at what the evidence was for them. So it's the same kind of thing. How many trials had been done comparing them to not doing it? Because that's actually very uncommon. I'll show you how uncommon it is. So we looked at a whole lot of procedures, and you can just look down this left-hand side here, rotator cuff repair, disc replacement, knee arthroscopy, of course, very common, carpal tunnel, shoulder replacement, knee replacement, all these these are very common procedures done for pain. And we looked, well, how many procedures have been done? How many randomized controlled trials are there in that field? Any kind of randomized controlled trial. How many of them compared doing the surgery versus no surgery? And then how many of those were favorable? And so this is what we found. This is summarizing it all together. We found over 6,000 randomized trials had been published. Interestingly, only 64, or less than 1%, of all of the randomized trials that we found actually tested the procedure against not doing the procedure. It was very uncommon. And in only 9 out of those 64 was surgery found to be favorable. We looked at how many of them had patient blinding, because I think that's very important that patients are blinded. 12 of them had patient blinding. That was actually pretty good. And in those 12 studies, none of them showed surgery to be superior to not operating. So that's the sort of kind of evidence we have. And you look at other things. So you look at a lot of pills that are produced. Look at the COVID vaccines, or look at pills for diabetes. All sorts of things. And these pills get tested against not taking the pill. But when we do surgery, we don't test it against not doing the surgery. We just assume the surgery works. It's only later when we do the test that we find out that it doesn't.